Welcome back to the great adventure of pediatric pulmonary physiology. This is the 14th presentation in a series of 30, and this is pulmonary function testing, part 6, preoperative assessment of postoperative risk. Again, this is the great adventure, pediatric pulmonary physiology, and as you can see, we're moving along. We want to approach this with the enthusiasm of a child in a candy shop. And just to recap the last several presentations, there are basically two abnormal pulmonary function testing patterns: restrictive lung disease, which is decreased lung volume, stiff lungs, and obstructive lung disease, which is increased airway resistance and decreased maximal expiratory flow rates. Now we're going to digress a bit from pure physiology and go a little bit clinical. So as pulmonologists, we are often asked to, quote, clear children for surgery. Well, what does that mean? So we're going to talk about why do a preoperative evaluation. We're going to talk about postoperative fall in pulmonary function, preoperative prediction of postoperative risks, and preoperative reduction of postoperative risks. So why do a preoperative evaluation? Children with respiratory disease are at greater risk of developing postoperative complications. Unsuccessful surgical outcome is less due to the operative period itself. That is, generally speaking, they're being watched over by anesthesiologists to control ventilation, oxygenation, etc. The outcome is determined more by how much and how long respiratory function is impaired postoperatively. So we need to consider how the child will look postoperatively, not how he or she looks when we see them in the preoperative evaluation. A preoperative assessment, what we need to do is to balance risks versus benefits. So what is the benefit of the surgery? What are the risks of serious or lethal pulmonary complications postoperatively? There's obviously no choice in emergency surgery, but this series of questioning, or type of questioning, is relevant to semi-elective surgery in children with moderate to high risk from pulmonary disease. So, questions that might be asked preoperatively. Should the surgery be performed at all? Should the procedure be modified? What is the optimal timing and preparation? Should the patient and family be warned about the possibility of postoperative problems, such as the need for prolonged ventilatory support while intubated, for example? So obviously a skillful history and physical examination are starting points, but there are limitations. If a patient has daily symptoms, she may only notice changes, even though baseline function is important to determine. Lung disease patients may adopt a sedentary lifestyle, masking true limitations. The physical examination at rest may not detect abnormalities. So listen to a forced exhalation, not just quiet breathing. Ask the patient to cough and observe the strength. This is especially important in patients with neuromuscular disease or suspected ventilatory muscle weakness. Always ask them to cough. Sometimes you're going to get something that's like this. And that's the best they can do. That's clearly an inadequate cough in a patient that may benefit from some sort of a cough assist device or other techniques or technology. If the patient has secretions, does the cough clear them? Postoperative respiratory failure is not simply lung failure, it is muscle failure. Now remember, we've been talking about, or we will talk, sorry, about the respiratory balance and the importance of respiratory muscle power to overcome the respiratory load. So search for signs of skeletal muscle weakness, especially ventilatory muscle weakness. And again, hearing a cough is one way to do that. If patients have the same preoperative lung function, the one with ventilatory muscle weakness will do worse postoperatively. Here's the problem. If we had an ideal clinical observation, if we had an ideal way to assess the actual amount of physiologic function, okay? So if an individual has a fall in physiologic function to, let's say, 75%, can you in fact detect that? All right, and the answer is we don't have this. So clinical observations at the moment there can be quite a bit of fall, functional fall, in physiology before we start to note a fall, right? So it's only out here that we think there's a 50% fall, but we're already down to less than 25% decrease in physiologic function. Pulmonary function testing does not approach this ideal situation, but does improve our ability to observe. So as you can see here, we have a bit more accurate reflection of decrease in function. So we want to predict how the child will look postoperatively, not how he looks in the preoperative assessment. So how does surgery affect postoperative lung function? How can we best predict how a child will do? And what can we do preoperatively to reduce the postoperative risk? That's the whole purpose of this. So postoperative fall in pulmonary function. What is the primary determinant of postoperative fall in lung function? Well, the answer is it's like real estate. It's location, location, location. So these are number of studies that show the postoperative fall in lung function depending on where the surgery was performed. So upper thoracic or abdominal surgery, or I'm sorry, thoracic or upper abdominal surgery, for example, there's a fall in vital capacity of a mean of 60%, FEV1 53%, peak flow 75%, and FRC 30%. Lower abdominal surgery is not quite as bad, but there still is a fall in vital capacity of 25%, FEV1 26%, peak flow 48%, and FRC of 14%. Extremities or face are generally associated with relatively little fall in postoperative function. If you've had surgery on your finger, it doesn't hurt you to cough, for example. But if you've had surgery here, it is going to hurt you to cough, and therefore you may not cough, predisposing yourself to pneumonia. Surgery on the extremities or face generally have a fall of only 8 or 9%, peak flow 12%, and FRC about 3%. So the location of the surgery is extremely important in terms of predicting the fall in postoperative. These are the same data plotted graphically, and you can see that obviously thoracic or upper abdominal surgery has a major decrease in all of these parameters. Lower abdominal, not quite as much, and face and extremity, the least. This is kind of the convention. Thoracic or upper abdominal surgery will follow 50 to 75%, lower abdominal 25 to 50, extremities or face 10 to 25. This is actually an example of a post-op PFT changes in a 9-year-old following an uncomplicated pulmonary valvulotomy. This is obviously thoracic surgery, and this is before they could be done non-invasively. And you can see that for all of these parameters, forced vital capacity, FEV1, FEV25, 75, and inspiratory capacity, there was a pretty dramatic fall to about 40% of the initial value by the fourth postoperative day, stayed down to about the sixth postoperative day, and then there started to be some recovery up into a week, but it's still considerably lower than the preoperative values. So scoliosis. Scoliosis is a problem, and this is just a chest CT in somebody with relatively severe scoliosis. And the problem is that there is less room available for the lungs. You can see that this lung is really compressed, and even this lung is relatively smaller in scoliosis. So obviously scoliosis surgery, what we want to try to do is to straighten the spine and increase, if possible, this area available for the lung, or volume available for the lung. So Nancy Ewan was a postdoctoral fellow with us in pediatric pulmonology 2000 to 2003, and she did a very nice study where she took a spirometer initially to the pediatric intensive care unit and then to the ward, and she measured spirometry in patients not with neuromuscular disease but other scoliosis patients for 10 days postoperatively. And you can see if this 100% is the pre-op value, by the first 5 days or so, pulmonary function is actually less than 40%. This is forced vital capacity, less than 40% of the pre-op value, and it kind of moves up. But by 10 days, it's still only slightly greater than half. FEV1 shows a similar pattern, although it dips a little bit here. It seems to recover a little bit more quickly than the vital capacity, but it's still down to about 3/4 the preoperative value at 10 days postoperatively. 2 to 3 days to 4 days is clearly the worst. And here we're down about less than 30% of the pre-op value. So lung function decreases by over 50% post-op for thoracic surgery. Now, we want an inspiratory capacity of 15 mLs per kilo to breathe adequately. So if that's the case, you need an inspiratory capacity of at least 30 mLs per kilo preoperatively to predict that you will not need prolonged postoperative ventilation. So the inspiratory capacity is kind of a usable vital capacity. Remember, vital capacity is all the way in to all the way out. But if you're post-op and hurting, you're probably not going to breathe down here. So the inspiratory capacity basically measures full inspiration to the end of a normal breath or GRFRC. And again, the determinant of this fall is primarily location. Post-operative fall in lung function is most severe when surgery is performed in the chest or abdomen. Post-operative fall in lung function is minimal after face or extremity surgery. What about preoperative prediction of postoperative risks? Can we predict which children will have significant postoperative difficulties? So Yogi Berra, the great Yankee catcher philosopher, said the problem with predicting the future is that it hasn't happened yet. So taking this into account, scoliosis surgery is thoracic and upper abdominal surgery predicted to decrease post-op function by greater than 50%. There's a high risk of postoperative complications due to pulmonary disease, and predicting postoperative complications preoperatively may allow intervention to reduce these risks. So again, Nancy Ewan did a study looking or basically addressing the question, can we use pulmonary function testing to predict the need for prolonged postoperative ventilatory support? So she looked at data from scoliosis surgery patients performed on 284 patients at Children's Hospital Los Angeles from 1990 to 2001. 125 were able to perform pulmonary function tests. 42, that is 32% of that 125, required prolonged ventilatory support postoperatively greater than 3 days. And 3 days was chosen as the definition of prolonged ventilatory support because 97% of adults following scoliosis surgery require less than 3 days of post-op ventilatory support. Those patients that required prolonged postoperative ventilatory support are shown in red bars, and those that required ventilatory support for less than 3 days are shown in blue bars. So if we look at the diagnosis here wasn't particularly helpful. Most patients with idiopathic scoliosis, for example, did not require prolonged support or even congenital scoliosis. However, patients with neuromuscular disease, a greater proportion required prolonged postoperative ventilatory support than did not, and that was statistically significant. Syndromes or tumors made no difference. Kyphoscoliosis made no difference. So most patients with diagnoses of neuromuscular disease required prolonged ventilatory support post-op, and that's significant at the P less than P0001 level. After removal of neuromuscular disease, other diagnoses were not predictive of the need for postoperative ventilatory support. So by knowing what their disease is, you could not predict if they needed prolonged postoperative ventilatory support. However, pulmonary function testing is helpful at predicting prolonged postoperative ventilatory support. So here you can see total lung capacity has a significant difference between those who required post-op ventilatory support versus didn't, a significant difference in values. Vital capacity similarly, inspiratory capacity similarly. Residual volume was not significantly different. FEV1 was. Maximal inspiratory pressure actually was just above being statistically significant. Similarly, if we look at sensitivity and specificity of these tests, total lung capacity was not particularly sensitive, but in terms of predicting, but reasonably specific. Vital capacity was more sensitive, not as specific. Inspiratory capacity also relatively sensitive. FEV1 plus minus sensitive, but not specific, but was specific, sorry. MIP kind of plus minus in either direction. Neuromuscular disease is a diagnosis again, was quite sensitive and specific. So that shows a little bit about the ability of pulmonary function tests to help. So scoliosis patients with the following PFTs were more likely to require prolonged postoperative ventilatory support. FEV1 less than 40% predicted, vital capacity less than 60% predicted, inspiratory capacity less than 30 mLs per kilogram, total lung capacity less than 60 milligrams, 60% predicted, and maximal inspiratory pressure, now preferably called P inspiratory max, less than 60 centimeters of water. Using multivariate logistic regression to predict the need for prolonged ventilatory support, greater than 3 days following scoliosis surgery, the most important parameters, interestingly, were in age greater than 13. FEV1 less than 40% predicted, and the presence of neuromuscular disease. And you can see the odds ratio were very high for FEV1 and for neuromuscular disease. When predicting the need for prolonged ventilatory support in children following scoliosis surgery, the most sensitive PFT was a vital capacity less than 60% predicted. Most specific PFT was an FEV1 less than 40% predicted, and the presence of neuromuscular disease, as mentioned, was also a strong predictor. In children undergoing scoliosis surgery who could not perform PFTs, no parameters from the polysomnogram predicted prolonged ventilatory support, and no parameters from infant pulmonary function tests predicted prolonged post-op support. So here are the two parameters that are frequently measured in infant pulmonary function testing: compliance to the respiratory system and resistance to the respiratory system. And although the numbers are small, I think you can see that there really is no difference. There's quite a bit of overlap between those that required prolonged mechanical ventilation and those that did not. Polysomnograms also did not predict prolonged post-op ventilatory support in scoliosis. Baseline saturations not different, lowest saturations, baseline end-tidal CO2. In fact, it was higher in the ones that did not require ventilatory support here. The peak PCO2, apnea-hypopnea index. So children, again, undergoing scoliosis surgery who could not perform PFTs, parameters from infant PFTs or the polysomnogram were not helpful in predicting the need for postoperative ventilatory support. Pulmonary function tests are reasonable predictors of the need for prolonged post-op ventilatory support, but they generally predict for groups, not necessarily for individuals. The presence of neuromuscular disease, however, is a strong predictor. One of the reasons we do this is the opportunity for preoperative reduction in postoperative risk. So identifying a patient at high risk immediately improves outcome. This was a study that identified patients as poor risk based on pulmonary function testing and or whether or not they had a PCO2 or PCO2 greater than 54. They were randomized so that the treating physicians of half of the patients were told that their patient was at poor risk, and the treating physicians of the others were not. Okay, so the only difference was they all got PFTs. The treating physician said, listen, your kid is a high risk because of XYZ. The other physicians, nothing was said. And here was the difference. This is mortality. Okay, post-op mortality in patients in whom the physicians were not told of a poor risk had a 60% mortality. Patients of physicians who were told had a 22% mortality. All right. These latter physicians had the opportunity to try and do something to mitigate that poor risk, whereas these individuals presumably did not, since they weren't aware of that. So identifying a patient at high risk immediately improves outcome. When treating patients were told that a patient had poor risk, they could stop cigarette smoking, for example, give antibiotics if appropriate, give bronchodilators, start chest physiotherapy, modify or delay the surgical procedure. So these are things that one could do. The most important facet of preoperative evaluation is the modification of risk through appropriate preparation. And so the mantra here should be, correct everything that is reversible and prepare the patient for the remaining problems. Even chronic disorders often have a reversible component. So patients identified as high risk for prolonged ventilatory support, you can inform the surgeon and anesthesiologist. You can inform the patient and family. This prepares the patient for waking up with an endotracheal tube in place, and that this was expected and not due to some unexpected catastrophe. Lung disease preoperatively should be stable. There should be no recent exacerbations. In general, no acute viral respiratory infections in the previous 4 weeks, no acute bronchospasm and asthmatics, and adequate oxygenation and PCO2. In summary, what have we learned? Children with respiratory disease are at greater risk of developing postoperative complications. Unsuccessful surgical outcome is less due to the operative period itself. It's determined more by how much and how long respiratory function is impaired postoperatively. So you need to consider how the child will look postoperatively, not how he or she looks preoperatively. Surgery and general anesthesia decrease lung function postoperatively. The postoperative fall in lung function is most severe when surgery is performed in the chest or abdomen. Postoperative fall in lung function is minimal after face or extremity surgery. The location of surgery is important. Identifying a patient as high risk immediately improves outcome. When treating physicians are aware that a patient has poor risk, they can reduce the risk. History, physical, and pulmonary functions help predict postoperative risk. The most important facet of postoperative evaluation is the modification of risk through appropriate preparation. Correct everything that is reversible and prepare the patient for the remaining problems. Even chronic disorders often have a reversible component. Next time, we're going to continue with pulmonary function testing part 7, and we're going to look at tests of small airway disease. Now, I'm going to admit to you that this may not be super relevant for what most of you will be doing clinically or perhaps even in research, but the tests are of historical interest that I think you should be aware of, and we'll show you why. And in fact, I have used some of these tests in research studies in the past. So thanks to our producer director, Katie LeWinter, and thank you for joining me in this, the great adventure, pediatric pulmonary physiology.